we're going to discuss the topic of drugs for asthma, by Professor Saminat and Kairohanam. Next slide, definition and meaning of asthma continues. An expert panel of the National Institutes of Health, the National Asthma Education and Prevention Program, NEP, has provided the following working definition of asthma. Asthma is a chronic inflammatory disorder of the airways in which many cells and cellular elements play a role in acute bronchoconstriction, in particular, mast cells, eosinophils, T lymphocytes, macrophages, neutrophils, and epithelial cells. In a normal person's bronchial tube, the muscle of the bronchi are relaxed and allowing easy airflow and no issue in breathing, but, in the case of asthma patients, the bronchial tube is inflamed and filled with mucus. Also, the muscle of the bronchi is tight and thicker, which impedes airflow and create difficulty in breathing. Next slide, normal values for peak expiratory flow. Peak flow measurement is a quick test to measure air flowing out of the lungs. The measurement is also called the peak expiratory flow rate, PEFR, or the peak expiratory flow, PEF. Peak flow measurement is mostly done by people who have asthma. Peak expiratory flow, PEF, is measured in liters per minute. Normal adult peak flow scores range between around 400 and 700 liters per minute, although scores in older women can be lower and still be normal. The colors used in each zone come from the traffic light. Green zone, 80 to 100% usual or normal peak flow rate signals all clear. Green zone, 80-100% of personal best, signals good control. Yellow. This means caution or slow down. The yellow zone is 80% to 80% of personal best. Measurements in this zone are a sign that large airways are starting to narrow. Red zone, less than 50% of the usual or normal peak flow rate signals a medical alert. This zone indicates that there is severe airway narrowing. Take quick relief medicine right away. Contact a healthcare provider right away or go to the nearest emergency room. Step 1, mild intermittent. BEF or FEF1 not less than 80%, BEF variability less than 20%. No daily medication is needed. Severe exacerbations may occur. A course of systemic corticosteroids is recommended. Step 2, mild persistent. BEF or FEF1 not less than 80%, BEF variability 20 to 30%. Low dose inhaled corticosteroids. Alternative treatment, listed alphabetically: cromolyn, leukotriene modifier, nidocromil, or sustained release theophylline to serum concentration of 5A15 mcg per milliliter. Step 3, moderate persistent. For FEF1 68-80% BEF variability more than 30%. Preferred treatment, a low to medium dose inhaled corticosteroids and long-acting inhaled beta-2 agonists, or low to medium dose inhaled corticosteroids and either leukotriene modifier or theophylline. Step 4, severe persistent. BEF not less than 80%, BEF variability more than 30%. Preferred treatment, high-dose inhaled corticosteroids and long-acting inhaled beta-2 agonists if needed, corticosteroid tablets or syrup long-term, 2 mg/kg/day, generally do not exceed 60 mg per day. Strategies of asthma therapy. The goals of asthma therapy are to decrease the intensity and frequency of asthma symptoms and the degree to which the patient is limited by these symptoms. Acute bronchospasm must be treated promptly and effectively with bronchodilators, reliever drugs. Long-term preventive treatment requires control of the inflammatory process in the airways. Controller drugs. Nasal oxygen is basic therapy for acute bronchospasm of any cause. All patients need to have a quick relief medication to treat acute asthma symptoms. Drug therapy for long-term control of asthma is designed to reverse and prevent airway inflammation. Drugs used in asthma. 1 short-acting beta-2 agonists: albuterol, valbuterol, perbterol, metoproterinol, epinephrine, isoproterinol. Long-acting beta-2 agonists: salmeterol, formoterol, terbutaline. 2 inhaled glucocorticoids: beclomethazine, triamcinolone acetate, betsnide, flunislide, fluticasone, propionate, cyclesnide, mometazone. 3 methylxanthines: theophylline, 4 muscarinic antagonists: ipratropium bromide, sheetropium, atropine. 5 antihistamines: diphenhydramine, loratadine, fexofenadine, clofeniramine, brompheniramine. 6 4 inhibitors: roflumilast. 7 leukotriene inhibitors: zafirlukast, montelukast, xyloton. 8 enzyme inhibitors: isocircumflex plus minus 1 proteinase inhibitor. 9 adrenoceptor agonists: oxymtazoline, phenylephrine, pseudoephedrine, epinephrine, isoproterinol. 10 antitussives: codeine, generic, hydrocodone, hydromorphone, dextromethorphanbenzone. 11 expectorants: guaifenesin. 12 mucolytics: N-acetylcysteine. 13 chromone, cromolyn, sodium. 14 anti-IgE antibody, omalizumab. 1 beta-2 agonists. They act as physiological antagonists of the spasmogenic mediators but have little or no effect on the bronchial hyperreactivity. Adrenergic agonists stimulate beta-2 adrenoceptors, causing an increase in cyclic adenosine monophosphate, CAMP, levels, which leads to relaxation of bronchial smooth muscle. These agents also inhibit the release of mediators and stimulate mucociliary clearance. Beta-2 agonists have no anti-inflammatory effects, and they should never be used as monotherapy. Some patients experience tachycardia, hypoglycemia, hypokalemia, hypomanzemia, palpitations, headaches, throat irritation, tremor, nervousness, restlessness, and tachycardia. Less common adverse reactions include insomnia and dry mouth. Uncommon adverse effects include chest pain, paradoxical bronchospasm, allergic reactions, and skeletal muscle tremors. 2 inhaled glucocorticoids. Corticosteroids are first-line agents for the treatment of persistent asthma. Corticosteroids inhibit the release of arachidonic acid through phospholipase A2 inhibition, probably by attenuating prostaglandin and leukotriene and inhibiting the immune response, including production of cytokines. Corticosteroids reduce the hyperresponsiveness of the airway smooth muscle to a variety of bronchoconstrictor stimuli, such as allergens, irritants, cold air, and exercise. Inhaled glucocorticoids. Cellular effect of corticosteroids. Corticosteroids produce direct anti-inflammatory properties by decreasing the inflammatory cascade of eosinophils, leukotrienes, macrophages, and T lymphocytes, also reversing mucosal edema and producing a significant increase in airway diameter. 3 methylxanthines. Theophylline and its compounds have been extensively used in asthma, but are not considered first-line drugs anymore. Theophylline is one of the 3 naturally occurring methylated xanthine alkaloids: caffeine, theophylline, and theobramine. Theophylline inhibits an intracellular enzyme, phosphodiesterase, mostly PT3 and PT4, leading to increased CAMP. Inhibition of PT4 seems to be the most important, that normally inactivates cyclic AMP. By inhibiting phosphodiesterase, levels of cyclic AMP increase in bronchial smooth muscle and in mast cells. The most frequent side effects from oral administration of theophylline are nausea and vomiting. Theophylline may cause vasodilation, and some patients experience flushing, headache, and hypertension. 4 muscarinic antagonists. In the respiratory tract, parasympathetic activation and release of acetylcholine cause bronchoconstriction and increased mucus secretion. By blocking the actions of acetylcholine, blocking M3 receptor, anticholinergic drugs produce bronchodilation and also reduce the volume of respiratory secretions. Anticholinergic drugs are not as potent bronchodilators as the beta-adrenergic drugs. Ipratropium is a quaternary amine that is poorly absorbed and does not cross the blood-brain barrier. Sheetropium, Spiriva, is a long-acting muscarinic antagonist approved for maintenance in COPD. Atropine is readily absorbed into the systemic circulation. The adverse effects of atropine include drowsiness, sedation, dry mouth, and blurred vision. These effects limit its use as an anti-asthmatic. 5. Antihistamines. Histamine is rapidly released from mast cells in the respiratory tract. Histamine causes bronchoconstriction, increased vascular permeability that contributes to mucosal edema, and infiltration of leukocytes, particularly eosinophils. Antihistamines. Competitive antagonism of histamine binding to cellular receptors reduces the parasympathetic tone of arterioles and decreases secretion through their anticholinergic activity. Antihistamines are more effective for the prevention of symptoms, rather than treatment once symptoms have begun. First-generation antihistamines, such as diphenhydramine and chlorpheniramine, are usually not preferred due to adverse effects, such as sedation. The second-generation antihistamines are generally better tolerated. 6. Phosphodiesterase 4, PT4, inhibitors. Phosphodiesterase 4, PT4, regulates the production of pro-inflammatory and anti-inflammatory cytokines. Phosphodiesterase 4, PDE4, inhibitors act by blocking the breakdown of cyclic adenosine monophosphate. PT4 inhibition leads to the accumulation of intracellular CAMP, which can activate protein kinase A, pKa, and cause relaxation and vasodilatory effects in target cells. PT4 inhibitors can suppress a variety of inflammatory cell functions that contribute to their anti-inflammatory actions in respiratory diseases. Phosphodiesterase 4, PT4, inhibitors have both bronchodilator and anti-inflammatory effects. Siavanleukotriene inhibitors, antileukotriene. Phosphodiesterase 4, PT4, regulates the production of pro-inflammatory and anti-inflammatory cytokines. Phosphodiesterase 4, PDE4, inhibitors act by blocking the breakdown of cyclic adenosine monophosphate. PT4 inhibition leads to the accumulation of intracellular CAMP, which can activate protein kinase A, pKa, and cause relaxation and vasodilatory effects in target cells. PT4 inhibitors can suppress a variety of inflammatory cell functions that contribute to their anti-inflammatory actions in respiratory diseases. Phosphodiesterase 4, PT4, inhibitors have both bronchodilator and anti-inflammatory effects. 8. Icircumflex apostrophe alpha-1 proteinase inhibitor. Alpha-1 antitrypsin, AT, is a protein produced in the liver that protects the body's tissues from being damaged by infection-fighting agents released by its immune system. A deficiency of AT allows substances that break down proteins, so-called icircumflex apostrophe alpha-1 proteinase, to attack various tissues of the body. The results disrupt the protease-antiprotease balance in the lungs, allowing proteases, specifically neutrophil elastase, to act uninhibited and destroy lung matrix and alveolar structures. Alpha-1 proteinase inhibitor is a serine protease inhibitor, SERPIN. Its primary mechanism is inhibiting the action of the serine protease called elastase, also plasmin and thrombin, in the lungs. 9. Alpha adrenoceptor agonists, nasal decongestants. All the nasal decongestants bind to the alpha-1 receptor and activate the phosphatidylinositol and release two secondary massages such as 1-inositol triphosphate and 2-diacylglycerol. These two secondary massages raising the intracellular calcium levels in the following way. 1-inositol triphosphate increase the release of calcium from intracellular stores in sarcoplasmic reticulum. 2-diacylglycerol increase the calcium permeability into the membrane. These two actions increase the calcium level in the and resulting in vasoconstriction. This leads to nasal blood vessels constrict and nasal pathway cleared and some relief in the nasal congestion. Unfortunately, the icircumflex plus-minus adrenergic agonist intranasal formulations should be used no longer than 3 days due to the risk of rebound nasal congestion. Rhinitis medicamentosa. Icircumflex plus-minus adrenoceptor agonists produce adverse effects that include nervousness, tremor, insomnia, dizziness, tachyphylaxis, dependence, and eventual mucosal necrosis. 10. Antitussives, cough suppressants. Coughing is an important defense mechanism of the respiratory system to irritants. Cough receptors, specialized stretch receptors in the trachea and bronchial tree, send vagal afferents to the cough center and trigger the cough reflex. A troublesome cough may represent several etiologies, such as the common cold, asthma, COPD, sinusitis, and/or an underlying chronic respiratory disease. Before treating cough, identification of its cause is important to ensure that antitussive treatment is appropriate. Opioids, codeine, hydrocodone, hydromorphone. Codeine, hydrocodone, and hydromorphone decrease sensitivity of the central cough center to peripheral stimuli and decrease mucosal secretions. Antitussive actions occur at doses lower than those required for analgesia. Dextromethorphan. Dextromethorphan is the L-isomer of an opioid. It is active as an antitussive but has less analgesic activity or addictive liability than codeine. It's less constipating than codeine. Benzonatate. Benzonatate is a glycerol derivative chemically similar to procaine and other ester-type anesthetics. Benzonatate reduces the activity of peripheral cough receptors and also appears to reduce the threshold of the central cough center. Diphenhydramine. Diphenhydramine is an H1 receptor antagonist. However, antitussive activity is probably not mediated at this receptor. Diphenhydramine acts centrally to decrease the sensitivity of the cough center to afferents. 11. Expectorants. Expectorants reduce the thickness of mucus and make secretions in the airways thinner. By loosening up the mucus in these ways, expectorants make it easier for a person to cough up phlegm and clear out their throat. The primary action of expectorants is to increase respiratory secretions, which lubricate and help liquefy mucus. Expectorants stimulate the production of watery, less viscous mucus. They include guaifenesin. Guaifenesin acts directly via the gastrointestinal tract to stimulate the vagal reflex. Neurometic doses of guaifenesin are required for beneficial effects. These doses are not attained in typical OTC preparations. Guaifenesin functions to decrease the viscosity of the mucus, which means it is more like water and thus easier to cough up, which alleviates the chest and airway congestion associated with many respiratory infections. 12. Mucolytics. N-acetylcysteine, bromhexine, ambroxol, carbocisteine. In various conditions, such as asthma, bronchitis, and respiratory infections, the production of mucus increases and mucus becomes purulent. In these situations the mucus thickens and also contains glycoproteins, cellular debris, and inflammatory exudate. These changes in the mucus make it difficult for the respiratory tract to remove the mucus by way of the mucociliary escalator system. When increased production and thickening of mucus contribute to airway obstructions and interfere with normal respiration, mucolytics are administered by aerosol to thin or liquefy the secretions. Mucolytics are chemical agents that liquefy bronchial mucus. Then, the mucus and other respiratory secretions can be removed by coughing. N-acetylcysteine, mucosal, is an effective mucolytic that contains a chemical group, sulfhydryl, that cleaving disulfide bonds apart the glycoproteins in bronchial secretions. Bromhexine is the synthetic derivative of vasicine. Alkaloid equals adatodavasica, thinning fragmentation of mucopolysaccharide fibers and decrease the viscosity of sputum. 13. Allergic agents. Cromolyn. Nidochromylallergic conditions involve the interaction of an antigen, foreign protein, and an antibody, produced by the body. This interaction causes the release of histamine and other chemical mediators from mast cells that then trigger an asthmatic attack. Cromolyn sodium is a drug that interferes with the antigen-antibody reaction to release mast cell mediators. The drug is taken prophylactically, before allergic exposure, on a daily basis. Cromolyn is also useful in allergic conditions affecting the eyes, nose, and gastrointestinal tract. However, it is not useful in managing an acute asthma attack, because it is not a bronchodilator. Cromolyn is available as a nebulized solution for use in asthma. The most frequent adverse effects of cromolyn are nasal stinging, nasal irritation, headache, and bad taste. In addition, allergic reactions have occurred involving rash, hives, cough, and angioedema. Nadochromyl is a drug similar to cromolyn in mechanism and pharmacologic effect. It is administered by oral inhalation, usually 2 inhalations 4 times per day. 14 interleukin-5 receptor antagonists mepolizumab, rislizumab, benralizumab. Interleukin-5 is produced by CD4 plus Th2 cells, mast cells, eosinophils, and basophils and is involved in many aspects of eosinophil development. IL-5 synergizes with otaxins, thus contributing to recruit eosinophils to asthmatic airways. Through binding to the interleukin-5 receptor, interleukin-5 stimulates B-cell growth and increases immunoglobulin secretion, primarily IgA. Indeed, high levels of IL-5 and otaxins were found in induced sputum from patients experiencing acute asthma exacerbations. The interleukin-5, IL-5, receptor antagonists mepolizumab, rislizumab and benralizumab are recent biologics indicated for the treatment of severe asthma with an eosinophilic phenotype. IL-5 antagonists are monoclonal antibodies that reduce the production and survival of eosinophils, which is a major factor in the inflammation seen in patients with severe asthma. Adverse effects include sore throat, myalgia, antibody development, and injection site reactions. Disclaimer: this channel does not promote or encourage any illegal activities, and all contents provided by this channel are meant for educational purposes only. Any copyrighted material on these slides is included as fair use for educational purposes only. It will be removed at the request of copyright owners.